Good evening, everyone, and welcome to Momcology's educational webinar series, The Caregiver Lounge. We're so happy you found some time to join us tonight. I'm Kim Buff, and I'm the founder and executive director of Momcology. We are really pleased with the wonderful response to this month's topic, Understanding Educational Challenges, with our panel of speakers from Nationwide Children's Hospital. We understand that registrations are still coming in. Layla from Momcology is working her best to get everyone in as quickly and as smoothly as possible. So thank you for your patience. I think that we even may have some international caregivers with us tonight on this Zoom. So a special shout out to those parents for finding us and this resource. So hello from the States and well done. Before we get started and I introduce tonight's speakers, we have a few necessary housekeeping notes. This webinar is in view-only mode, so we can't see or hear you. So please feel free to get as comfortable as you'd like. Please use the dedicated question and answer box at the bottom of your screen for any tech issues with this webinar or to leave questions for our panel. We'll be having an open Q&A with our panelists as part of this webinar at the end. With that, I'd like to welcome our presenters. We have a series of PowerPoint presentations tonight, and rather than hear me talk more, if our presenters can take a moment to briefly introduce themselves before they get into their individual content, I think that will probably work best. And I think we can drop their bios in the chat also during each of the presentations. So welcome, panelists. We are grateful for your insight and support tonight. And I will now pass it to our first speaker, Dr. Kristen Hoskinson. Welcome to the Momcology Lounge.
Right. Well, thank you all so much for having us. I know that all four of us are really excited to be here tonight and appreciate you taking some time out of your day to hear what we have to say. So my name's Kristen Hoskinson. I'm a licensed pediatric neuropsychologist at Nationwide Children's Hospital. And my primary background is using mostly imaging methods to look at changes in the brain and how that affects learning and development in kids with different chronic illness conditions. The four of us, again, will be presenting on understanding educational challenges for children after cancer treatment. So none of the four of us have conflicts of interest to disclose. And I'm going to lead us off today just talking about some of the neurocognitive difficulties children can face across a wide range of types of pediatric cancer. And starting off just with this slide, not to gather the details from it. I know that this is very busy and tiny font, but the point I'm trying to make with this slide is just that across these different age bands, so A, B, C, D, and E are reflecting different age groups. There's a wide variety of types of diagnoses that children and adolescents face. And so we're really talking about, pediatric cancer as a wider group of diagnoses that may carry kind of a varying level of risk for cognitive challenges. But really, I think it's helpful to kind of root ourselves in the fact that this is a really wide range of diagnoses, a wide range of treatments. And because of that, it can feel really challenging to pinpoint the amount of risk of having cognitive challenges after treatment. And why sometimes for us as researchers, it can be really challenging to work with families to know what to anticipate. But what we know collectively is that across these different diagnoses, there are approaching about 10,000 new diagnoses per year, and this is specific to the United States. And fortunately, over the past 4 to 5 decades, there have been a lot of improvements in treatment and in how cancers are detected and diagnosed that has contributed to this really rising overall 5-year survival rate, now exceeding 85%. And that's owing to the three kind of mainstays of treatment that include, for some diagnoses, surgical resection, and then different types of radiation therapy and chemotherapy being kind of the main three. And what we know from kind of decades of literature at this point is that there are some difficulties that even though this treatment is life-saving, life-preserving, there are some kind of the cons associated with them. So impacting things like thyroid or lung function or heart function. Not that we would kind of spare going into those treatments, but that we do look out for after treatment ends, just something to keep on the radar. And what I'll be talking about in a little bit more detail up here in the top right are cognitive deficits or cognitive difficulties, and what might be contributing to those difficulties in kids. And so when we think about these kind of neurocognitive or our cognitive deficits, they really span different areas of thinking skills. And so kind of overall intelligence or problem solving, also what we term executive functions. So these are the more complicated skills that we all kind of get better at as we get into the teenage and adulthood years. Things like being able to control our impulses and problem solve and manage multiple bits of information at once, memory skills, and this all leads to sometimes, unfortunately, some difficulties with academic achievement. Difficulties is in some cases owing to the cancer diagnosis itself. So one clear example of this is for children who are diagnosed with forms of brain tumors. It can be because that tumor is laying on top of or kind of encroaching on some areas of the brain that help coordinate certain skills, and also can be a consequence of forms of treatment. So if a surgery is involved, if you need to go on a general anesthetic, or if the treatment involves something like radiation, all of those can have an impact. And in terms of kind of timing of emergence, we see that these are difficulties that can often be detected even during treatment, but tend to emerge over time into survivorship. And there's an idea that that these kids kind of grow into their difficulties as the demands of the environment get more and more complex. We know that risk is not evenly distributed across survivors, and there are some risk factors that have been kind of noted in different research studies. So when we think about age, the growing consensus is that kids who are diagnosed and treated particularly young or at critical neurodevelopmental, so brain development approaches, they may be at higher risk for having cognitive difficulties after treatment. There are always impacts of things like family history and genetics. And that's both for a risk of developing cancer in and of itself, and then also for some vulnerabilities for cognitive difficulties. Some of it is really just kind of owing to chance, unfortunately. And then there are contributing lifestyle factors. So these are things like area pollution and do you have access to physical fitness and activities, making sure that you're avoiding things like smoking. So all of those can also play a role, just like they can in adults while with cancer. And then again, there are some treatment factors. So things like the number of courses of treatment that are required for your diagnosis, type and doses of certain medications, particularly some of those chemotherapies, and then the type and dose of any radiation, whether that's systemic or craniospinal radiation. Okay, again, this is a slide. I don't expect people to kind of be pinpointing the individual lines here, but again, this is just a slide from a really nice recent paper by Olson and his team showing the variability in outcomes. So in each of these graphs, the y-axis, so the up and down axis, is showing performance on a different type of skill. So, processing speed here in this panel is being able to really think and reason with information very quickly. Verbal reasoning is being able to kind of problem solve using words. Verbal learning is being able to hold on to that information. And across all of these cognitive skills, the take-home message is that as years advance since diagnosis, so the x-axis or the horizontal axis is showing years post-diagnosis, here going up to almost 20 years post-diagnosis. And they show that in a lot of these skill areas as a whole, we see a decline. And so what that shows is that children are having more difficulty with these skills, or again, kind of growing into the weakness over time, but there's a ton of variability. So each of these little colored lines is one individual person, showing that it's not universal and that there's a lot of, variability. There are a lot of contributing factors that we're having to muddle through, both as researchers and providers, and also as family and as teachers, and those providing supports for these kiddos. And so the way that I think about the consequences of pediatric cancer is that there are these, factors that are really central to the diagnosis, to the treatment, and that those things can disrupt different processes in the brain. And so for me, I have my tendency is to always root it back to what's going on at a brain level. And we know that there are a lot of changes that are just happening in kids' brains as they get more mature. And that some of these brain structures, so the different kind of volumes and the kind of spatial relationships of these parts of the brain, and then also the pathways that connect one region to another, can be impacted by a cancer diagnosis or its treatment. And that when you impact those kind of more mature brain networks, what happens is you start having difficulties with these more complex skills. So thinking really quickly, problem solving, paying close attention and being able to shift your attention from one thing to another. And that it's those kind of what we call higher order, more complex problem solving skills that end up bleeding into what we see in the classroom. So it may contribute to problems with academic achievement. So math performance, reading performance can also contribute to things like what we call graphomotor control. So being able to manipulate like a pen and pencil, and then also to self-control in the classroom that can lead to behavior problems. And this is just one piece of really what goes into what can, again, be observed in a classroom environment or in the home, where kind of these neurocognitive factors are one piece of a very complex puzzle, where you also have, maybe changes in your mood and changes in parts of your physical appearance after treatment, missing out on normal day-to-day social interaction and just being in the classroom, and missing out on, learning how to be a student, learning how to, sit still during classes and take notes. And then variance in stakeholder knowledge. So this is, whether you are in a school that has ever supported a family where a child has cancer before, whether families are well informed about their rights to educational accommodations and resources in the community. And all of that can bleed into some struggles in the academic setting, and then that can also contribute to poorer performance. So it really is kind of this messy Venn diagram of factors that hopefully we can address with, really thoughtful intervention. And so when we're thinking about different ways to assess these kiddos, it's important to consider, what is your baseline? Where are you starting? And the tricky thing about childhood cancer is that it can be really, really difficult to figure out what is the best time to do an assessment. And, families deal with so much in the acute diagnosis period and during treatment, and, tossing a cognitive evaluation in there can be really complicated. Symptoms right after diagnosis can really kind of ebb and flow. There can be a lot of fatigue. If you have a diagnosis that directly involves the brain system, there can be some changes in consciousness. And so it can be really difficult, even just physiologically, to do that assessment, let alone, contributing and trying to fit it in, given it's a very distressing period. And there really just isn't a ton of really solid longitudinal research, or research that kind of starts and then follows children over time, that would drive some of these decisions. But I did want to provide, this is one proposal that Pancaldi and colleagues published last year, about when, this is specifically in the context of pediatric brain tumor, might be opportunities to conduct assessments. So, timing it around surgeries, timing it around treatment approaches that can be particularly damaging to brain systems. And here I'm thinking specifically about certain types of cranioradiotherapy, and then following children over time. And so again, we know that there are changes that can occur even years after treatment. And so making sure that we're continuing to engage with families to provide that support as kids kind of work their way through the education system, and then provide supports that will take them into adulthood. And so I did want to just provide some assessment considerations here, working really collaboratively. And I know one of my co-presenters will talk about a case later that will reflect this. Um, but really collaborating with the school system, knowing that survivors have really unique needs and that schools aren't always familiar with some of those challenges. It may be that the school system has never had a family where a child was attending their school who was a survivor. And so I think working with developing interventions that are really kind of tuned into the needs of survivors. I usually recommend trying to get a designation for those of you who are familiar with an IEP or an individualized education plan. They have different designations. And so those designations, it could be under something like a learning disability designation or a physical impairment designation. I like to encourage families to consider, if they can, one called other health impairment. And for those who have, diagnoses that more directly involve the brain, for a traumatic brain injury designation, just because those provide access to the greatest variability of interventions and kind of leave you starting off with the most options. And so I did just provide, a couple of slides of what the cognitive concern is and then what that might really look like. So for instance, if a child has slowed processing speed, so they take a little bit more time to come up with answers or to think on their feet, what that looks like in the classroom is just having trouble with time constraints. So time tests or standardized tests or even completing a project within a time, like a class period. And so encouraging things like extra time and no time limits on tests or standardized test accommodations. Whereas something like at the bottom, so fine motor speed, so that's kind of writing and manipulating paper and pencil, can really cause some difficulty with note taking. So one of my recommendations here is not to immediately remove the need to take notes because that's a good fundamental skill, but to pair them up with a child in the class who is more skilled at note taking and to provide those as supplementals, to provide audio recordings or kind of a schematic or a kind of the lesson plan of the day that they can use to supplement. Similarly, we talked a little bit earlier about these executive function, these kind of more complex problem solving skills. The number one thing I see with that is trouble with organization. This becomes a big issue when kids transition to especially middle school and then make the jump to high school, where all of a sudden they have a locker and they're changing classes and they have different teachers. And that addition really is one of the things that I think best reflects kind of growing into a weakness, where if you're in second grade, you're with the same teacher all day, you have your desk in your classroom, that organizational weakness may not be as apparent as it is when the demands of your environment change. And so at this point, I am going to hand it over to Dr. Gerhardt to talk about the late effects in development and transition to adulthood.
There we go. Thanks, Kristen. This is really helpful to get a sense of some of the neurocognitive or academic challenges that kids may have. I should introduce myself real quickly. I'm Cindy Gerhardt. I am the Chief Clinical Research Officer at Nationwide Children's and have been doing work with families of children with cancer for my entire career, so 25 to 30 years now. And it's been my love to work with these kids and families. So I'm really happy to be here and chat with all of you. So I wanted to talk a little bit about, for some of you, you're in the midst of treatment and thinking about how this is impacting your child in the short term. I also wanted to speak to some of the long-term survivors and parents who are trying to manage some of those transitions in later adolescence and early adulthood. And we know some of these neurocognitive difficulties may cascade or lead to some challenges in other areas. So, if children are having difficulty in school, they might also begin to have some social challenges or feel a little bit worse about themselves or have some challenges emotionally as they traverse through elementary, school, middle school, and high school. So we have been doing some work to understand this a bit better. Hoping this will go. There we go. So one of the things we wanted to look at is how some of these neurocognitive challenges cascade into or reflect in the social well-being of children. And so a fair amount of our work is focused on how kids are doing in the classrooms when they integrate back to school. And what generally we found across multiple studies is that children who have um, cancers that are non-CNS related, so those who don't have brain tumors or those who haven't had any CNS directed treatments, seem to do just as well as their peers when they get back into the classroom in terms of how they behave, how they get along with the other classmates, and also their friendships and the quality of those friendships. But what we find is, again, those children who have some of the more neurocognitive risks tend to have more challenges socially when they return to school. Some of them may have a little bit more difficult time initiating into social activities, may be more isolated or teased. And we find they may have more challenges with establishing or reestablishing friendships. So, what we've begun to do is look at what are the specific social skills or social cognitive skills that may be affected by cancer treatment. And what we find is that there are multiple types of social abilities or social skills that may be affected. Particularly, we find that some of our children who've had a brain tumor or have a fair amount of central nervous system treatment, so intrathecal chemotherapies or cranial radiation, as Kristen talked about, they tend to have more difficulty like reading emotion on faces. They're actually less likely to look at a face. They're more likely to kind of divert their attention and look at hands or other parts of the bodies instead of maintaining eye contact. They're more likely to kind of have negative attributions for behaviors. And they have a difficulty kind of putting themselves in other people's shoes, what we call theory of mind, or being able to take the perspective of others. And these kind of are also evidenced in some of their challenges with just managing some of those more subtle social abilities like understanding irony or sarcasm. And in fact, some of our neuroimaging research begins to help us understand what aspects of what we call the social brain may be affected by different kinds of treatment. So we're beginning to learn a lot more about how both the combination of these neurocognitive difficulties and social cognitive challenges may affect kids early in treatment. So one of the questions we had in our lab was, how do those early social challenges and neurocognitive difficulties affect later development as kids grow into adolescence and young adults? And one of the things we know is that when we get to adolescence and emerging adulthood, a classic sign of this developmental period is that there's lots of change that happens during that time. So those of you who have teenagers or young adults know that there's a lot of instability. You are working on education, and some of the things you might study in college may or may not be related to what your later career is. You may be working part-time jobs or working a variety of different jobs that may not have any relationship to what you end up doing as an adult or in your career. You end up trying out different partners and dating to learn about who you like or what kinds of qualities you value in a partner, and then you begin to kind of settle in and think about more of a stable career path and becoming a parent and starting your own family as you get further into adulthood. So one of the things that we know about our survivors is that they're managing some of these developmental transitions with a, a history of some of the neurocognitive challenges. And then they also have other physical late effects that may affect, their ability to attend college or work at different kinds of jobs. So some of these physical challenges like pain or fatigue, as we often hear about, or other health behaviors may get in the way of being able to achieve some of these goals that they have. We also know that there's some risk. It's we don't find severe psychopathology in our cancer survivors, which is great. But particularly those who may have neurocognitive challenges, they may have more difficulty coping with some of the normal stressors in life. And so they may be at a little bit higher risk for some emotional challenges. And we see including some fears of recurrence and or distress related to sexual functioning or fertility as they get older. So these are some things that we wanted to understand a bit better as our survivors grew up. We also wanted to kind of focus on what some of the normal developmental milestones are in later adulthood. So what we hope is that for all of our kids, once they get through treatment, we keep them as happy and healthy as possible throughout their long-term follow-up. And we wanted to know, like, how did they do in terms of just meeting normal, socially valued milestones? So those milestones like graduating from high school and college, getting married, or establishing intimate relationships and friendships, and having their own family. So I'm going to tell you about some work we did with our colleagues in the Netherlands, and we followed about 300 young adults who were 20 to 40 years old. Half of them had had cancer as a child and were at least 5 years post-diagnosis, and half of them were healthy controls from the community. And we wanted to begin to understand not only did they meet some of these milestones, but how did they feel about their life in general? Were they happy with when they met some of those developmental milestones? Were there differences in how kids were doing, if they had some of those neurocognitive challenges or not? And just in general, how satisfied were they with life as they grew up? So what we first did was look at some of the basic and some of you may not be here yet in terms of whether you have an adolescent or young adult survivor, but just when did they have their first kiss? When did they start to have some of these social milestones emerge? And how did they feel about the timing of that? So not just did it happen, but did they feel like it was at the right time? And for the most part, our survivors met those milestones at the same time as our healthy controls. The only difference is that they were about a year and a half behind in terms of their first intercourse. We also asked them about their relationship status. So one of my fellows in the lab had said, being married or not may not be the be all and end all for our survivors. And most of the literature had just focused on did they get married or not. And we know you can be perfectly happy being single, but also perfectly miserable being married. So we wanted to see, like, where were our survivors as young adults, and then were there differences in their rates of being single, in a serious relationship, or married? And what we found is that they were more likely to be single and less likely to be in a serious relationship than the controls, but just as equally likely to be married. And they were just as happy with their status and their relationship, as well as their value as a mate. So whether they felt like they were a good partner or not compared to controls. What we did find, though, is that, again, some of these survivors who had had early neurotoxic treatments or CNS disease, such as a brain tumor, tended to have more challenges. And in fact, it wasn't just whether they had a brain tumor or not that might predict some of these long-term social outcomes, but it was more sensitive, like if we looked at how neurotoxic their treatment was. So did they get some of those intrathecal chemotherapies and cranial radiation that might have disrupted some of those early neurocognitive functions, and also their ability to cope and kind of manage some of those social relationships. We also wanted to know, like, how does fertility knowledge play into this? And this may seem a little bit removed from some of the educational discussion that we've been having earlier in this talk, but we also know that fertility is a late effect that emerges, and both neurocognitive functioning and fertility can have significant effects on psychosocial functioning as kids grow up, and even in healthy individuals. So what we initially asked them is, had they heard about whether survivors might be at risk for infertility? And most of them had, and they learned this either from their provider or the internet or from their parents. But we did find that in particular, our brain tumors were least likely to know that there might be a risk for infertility or an impact on their ability to start a family. We also asked them, had they ever been tested, or did they know for sure they were fertile or infertile because they had tried to have kids? And what we found is that half of them had not been tested, or half of them didn't know. Many of them have found out because they were told, or they ended up having a pregnancy. But what we find again is that those who didn't know were more likely to be a brain tumor survivor or a solid tumor survivor. They were younger when they were treated, younger during our study time, and maybe not thinking about yet having kids or not. So, but what we also wanted to point out is that in both of these groups, those who knew about their fertility status and those who didn't, most of them still wanted to have additional kids or have a child. So one of the other questions that we asked them is, when did they feel like an adult? And so one of the things I often ask audiences is, like, what were the things that made you feel like an adult? Was it when you moved out of your parents' house, you got your first job, or graduated from college, maybe got married or had kids? So we asked our survivors, actually, if we just look at healthy adolescents and young adults, what they say is that in some ways they do feel like an adult, in other ways, no. And it kind of depends on, like, what kind of thing we're talking about, whether they're responsible for themselves, or they're able to make independent decisions, or they're financially independent. And it depends on who's with them. So when they're with their partner and coworkers, they feel more like an adult, but when they're with their parents or their friends, they may feel less like an adult. So our survivors, actually, most of them said they felt more mature than their peers, and they had to grow up faster than their peers. And they actually rated themselves as pretty high in terms of multiple aspects of their maturity. But again, we find that our brain tumor survivors were rated themselves as least mature, and actually reported lower overall life satisfaction. So what I wanted to kind of point out from this is that, paying attention and intervening early with some of the neurocognitive and social cognitive challenges that survivors have may reap some benefits in terms of how they end up adjusting and how fulfilled they are as they become young adults. So just wanted to say thank you, and we'll go to our next speaker, who's going to talk a little bit more about how we do intervene and what types of tools and resources might be available.
Hi, everyone. Thanks so much. So my name is Emily Moscato, and I'm a postdoctoral scientist and a psychologist at Nationwide Children's Hospital. I'm going to go ahead and request remote control for the slides. So hopefully this works okay. A lot of my work has really been focusing on how we can help support families of the youngest kids with cancer and helping set these children up for success in the long term. And I'm really excited to speak with you tonight about some of the psychosocial resources, tools, and interventions that may be helpful for your child or for your family more broadly. So what we know about psychosocial care as a whole, and fortunately in cancer care specifically, there's just been a broader focus on how can we care for the whole child. So not just physical and medical well-being, but also their mental health, and then their social well-being, and how they kind of do into the long term. And so another facet that's really important is thinking that care needs to be developmentally tailored. So we know, especially for the youngest kids, they may not completely understand all of the procedures and tests that are being done. And so we really need to take the time and the care to explain what's happening at a developmentally and age appropriate level for them. And then, as you all know, a diagnosis of cancer can tend to impact the entire family system. So caregivers, as well as siblings and extended family. And so as hospital staff and the entire team, we really try to think about how we can make our care family-centered as much as possible. And then lastly, we like to think about how we can make our care preventative. So rather than waiting for problems to kind of arise and come up, starting to think about how we can anticipate challenges and kind of give resources ahead of time. And so these are some of the members of the healthcare team within a hospital, and the names of these may vary from hospital to hospital, and it might look a little bit different depending on where you are. But we tried to star here some of the members of the psychosocial team that you may have as part of your team. So many hospitals may have a social worker, which can be a great place to start in asking what sort of resources might be available for your child and for your family. And you may also have access to a child or pediatric psychologist within your center. And psychologists, and all of us are psychologists on this call, we kind of specialize in coping and adjustment to the diagnosis for children, but also helping the broader family system kind of cope and adjust, and even into survivorship can be helpful. And you may also have access to a learning specialist, and these can come by different names depending on your hospital setting. You may have something called a school liaison, and this is an individual who can help kind of connect the hospital system to the school setting. They can also help you ask for accommodations, so things like an individualized education plan, like Dr. Hoskinson mentioned, or a 504 plan. You may also have access to a neuropsychologist. So Dr. Hoskinson was talking a lot about the neuropsychological assessments that can be provided. And this is someone who does IQ testing and academic testing to help see how your child's thinking and learning may be impacted by cancer. And then they can help make recommendations for support as well. And then one other one I wanted to point out was the child life specialist. And if you have access to a child life specialist, they can help you provide coping support, especially during procedures like scans or follow-up appointments, and explain things in a developmentally appropriate way to your child. And then we wanted to mention these psychosocial standards of care, which is a long list. We're not going to go through all of these in detail, but just something to be aware of. These were released in 2015, and they were published in a special issue of what's called the Pediatric Blood and Cancer Journal. And they were sponsored by another foundation called the Maddie Miracle Cancer Foundation. And their slogan is, "It's not just about the medicine." So these really provide some guideposts of care that, hopefully the hospital, wherever you are, is kind of checking in on your family and providing these different levels of care. And I think importantly, it's not just kind of during that active diagnosis and treatment period, but also, caring for you and your family even beyond into survivorship. And so, and then we know that not every family is going to need the same level of support. So some families are going to, do just fine, kind of with, casual check-ins. And this chart kind of shows at the blue level, the bottom, the universal level. When we think about psychosocial care, we kind of check in on everyone. We check in on how caregivers are doing, how children are coping, and to see what kind of support might be helpful. And then when you move up to the green level, these are families that might need more targeted levels of support, like child life, or maybe some educational planning might be needed. And then other families might need a little bit more tailored support and individual support in the orange at the very top of the pyramid. And they might benefit from the support of a psychologist or a therapist of some sort. And so one of those supports that can be really helpful for some families might be individual or family therapy. And wanted to note that even most child-focused therapy is going to involve caregivers in some way. So, whether that's just kind of being there to help support your child, for being involved in kind of planning and help supporting them between sessions, that's something helpful to kind of look for in a therapist. And one particular type of therapy that can be helpful is cognitive behavioral therapy. And this is a research-based method that involves helping kids and caregivers find effective ways to cope with stressors. And so this chart kind of shows you that through CBT, the therapist might help children and their parents either change what they're thinking or change what they're doing to change how they feel. And so this can be a really helpful therapy to look for. And you know, you might be able to go through your hospital to find some cancer-specific providers who are really comfortable with working with families who've been affected by a pediatric cancer. But if there's more general concerns like general anxiety or just feeling sad some of the time, and it seems to be maybe unrelated to the diagnosis, I think in those cases, it's okay to kind of seek supports wherever you are and find a provider close to your home. There are some more cancer-specific treatment options that may be available, one of which is called the TOPS program. It's the Teen Online Problem-Solving Intervention. And this is starting to be used with some families following pediatric cancer. And then we'd be remiss if we didn't mention that you know, caregivers definitely need and deserve their own support as well. And so, you know, there's a wealth of different caregiver support groups that are available, both through Momcology as well as through other societies. And we have some links embedded in the slides for you as well. And then, you know, if as a caregiver, you're continuing to struggle with intense feelings of worry or sadness, and these are really getting in the way of your day-to-day life, this is when it might be time to think about seeking some of your own professional support. And so your hospital team can definitely help you with referrals. But I also like to plug this Psychology Today portal where you can find a therapist in your area, and you can even search by you know, different insurance types, different types of therapy that you're looking for, different specializations. Or if you want specifically some virtual support, you can also select that option. And that can be a really helpful tool to look for. And so I wanted to include some words of advice from caregivers in some of the research studies that we're doing now. Because I think that, you know, you all say it best, and hearing it from another caregiver is probably worth way more than one of us saying it. But just these words of advice of taking care of yourself and not thinking that it has to be the entire day. So this caregiver says, just take little pieces of time. Looking back, I could have taken 20 or 30 minutes here, 15 to 20 minutes there. Nothing major that would have affected his care. And then the second piece of advice was telling your family the support that you need because they can't read your mind, and you don't have to do it alone. And the last one is talking to someone. Go ahead and just make that therapy appointment. If you have questions, talk to your doctors, and they don't feel bothered. They're there to help you. So straight from people who've walked in your same shoes. A couple other resources that we just wanted to mention is, as Dr. Gerhardt mentioned, you know, we know sometimes some kids may struggle with kind of forming friendships and, you know, connecting with other kids their same age, especially if they've missed out on a significant portion of school. And so some of the recommendations that our team has is to look for those group activities. So whether that's, you know, as it's safe to do so, kind of seeking out some teams or, you know, any type of club where they can kind of practice these skills with kids their same age. You know, parks and zoos might be a great place to start because sometimes that can feel like a safe option, especially if there's still concerns about the immune system at some point. And then there's also options to seek out social skills groups. Sometimes these might be found through your hospital, through your school, or even some virtual options. And any of these can kind of help build these social skills that I've included in this picture. So these are things like, you know, dealing with anger and frustration, or seeing another person's perspective, taking turns. And so these can be, you know, helpful things to look for in your area. And I would also say these social skills groups, it may be unlikely that you'll find one that's cancer specific, but a lot of kids can benefit even from just being around the other kids. So it doesn't necessarily need to be a cancer specific group for them to kind of benefit from that level of support. And then we did want to mention some other educational interventions and supports for children. So one is called cognitive rehabilitation. So these are things like you might have heard it called CogMed or some sort of training that children do on a computer. It also can be called something called neurofeedback. But what we know about this so far, and our research is really, really limited, is that it might help kids gain certain types of skills and they might get better at kind of these game-like activities that they're playing, but it might not lead to kind of widespread changes that you would notice in their day-to-day or school functioning. So at this point, it's not something that has, a ton of research backing, and so kind of proceeding with caution with those types of interventions at this point. What we do recommend is it might be more helpful to kind of focus either on like tutoring and getting kind of subject specific help, and definitely getting school accommodations in place. So the individualized education plans that Dr. Hoskinson mentioned, or the 504 plans, and just really, partnering with your school and seeing what recommendations they can put into place, I think is a great place to start. And then I definitely wanted to mention for any caregivers who have really young kids, so this is the less than age 3 group, there are home-based developmental supports that are available for free in the United States. And these are each state-specific programs. We have some links in our resources where you can see it's called by different names depending on what state you're in. Here in Ohio, it's Help Me Grow. But these are home-based services where professionals will come out to your home or even work with you virtually and provide an evaluation, and then they help you see what types of services might be helpful to help your child with development. Let's see. So in conclusion, just wanted to point out that encouraging all of you to really advocate and ask for the resources that may be available within your community and within your hospital, and always feel confident that you know your child and your family best. So these are more quotes from caregivers, just encouraging other caregivers to ask and to use their resources. And then just to wrap up and say that, many families have told us that that they try to focus on gratitude and hope whenever possible and to keep living life. So, accommodating things and accommodating changes, but not, letting it rule your life. And then other families also tell us that it helps, their family as a whole is stronger because of this experience. So with that, and we'll provide these resources as well. We've got many links for different caregiver supports, as well as education information for you, different school guides from different organizations, and then several different educational resources, a roadmap for requesting an IEP. That's a really helpful one to take a look at. It kind of walks you through the process of a timeline and how you might ask your school for these accommodations. And then if you do have an adolescent or young adult, we have some specific resources there. And then lastly, some different options for promoting social development and some different specific camp experiences that might be helpful for your families. And now I'll turn it over to Dr. Schaefer.
Thank you, Dr. Moscato. So my name is Megan Schaefer, and I am a pediatric psychologist also at Nationwide Children's. The bulk of my work is primarily clinical, so I work with kids of all cancer diagnoses, but I like to specialize in neuro. So we've heard a lot of great information from all of our presenters, so we figured we would end by wrapping all of the information to make it more applied to see what this would look like for a case example. All right, so I would like to introduce you all to Ben. This is a de-identified patient that I was able to treat alongside with his family. So he was diagnosed with medulloblastoma at the age of 8. And as Dr. Hoskinson was highlighting, there can be lots of different types of treatment. So because of his diagnosis, he was treated with surgery. He also underwent radiation and then chemotherapy. Some of the side effects that he noticed, both from where the location of his tumor was, but also from the treatment, was he had a lot of the balance difficulties. There was a lot of weakness. There were also fine motor difficulties. So when we're thinking about school, like writing and typing, or even eating meals, like being able to use his fork and spoon, some of those things were more challenging for him. And then to put into context, as Dr. Moscato was talking about, when we think about the impact on family, this family was also experiencing a lot of stressors in addition to Ben's diagnosis. So the one that I think is most important to note was a year before his diagnosis, Dad was also having a lot of neurological problems. And so when you think about all of the medical stressors they were balancing as a family, it really became a lot. And Ben's diagnosis was really unexpected. He presented to the hospital for like a very typical GI complaint, and then he accidentally had fallen down, and they did a scan to be proactive. So just the way in which the diagnosis was found also complicated coping in general. So to talk a little bit more about what Ben's educational history looked like. So when he was diagnosed, he was a third grader, and he did have a diagnosis of ADHD prior to cancer. He was actually on the wait list to be fully assessed for autism spectrum disorder. So that also ran in their family, and mom had been noticing some symptoms. So she just wanted to get that fully evaluated. And he was actually, I think it was like a week before he was diagnosed, where that evaluation was supposed to be. He did have some speech concerns, so that was something that the school was already working on with him prior to diagnosis. And they did also, from like an academic achievement perspective, they talked about some difficulties with reading comprehension. They described him as a very strong student in math, so he really enjoyed that and talked a lot about wanting to be an engineer. He liked how things got put together and solving problems. And he did already have a 504 plan because he was diagnosed with ADHD. So he was familiar with what that looked like and the accommodations that were helpful for him on that end. So I would like to really talk about the trajectory. And I think all of our presenters talked about the way that we support kids. It might look different from diagnosis to 3 months in to when they get to survivorship. And we know that challenges, but also ways in which they grow, ebb and flow over time. So when we think about how we supported Ben's academic and social functioning at diagnosis and through treatment, these were some things that we found particularly helpful and that the family really talked about this was beneficial in promoting these areas. So as Dr. Moscato was talking about, every hospital has a different psychosocial team. So here at Nationwide, we are lucky to have school liaisons that connect with the child's school to talk about setting up homebound instruction, talking about accommodations, educating classroom. But we recognize that not every hospital system may have that. So other people that can help outside of school liaisons may be a psychologist or a social worker or a nurse navigator. And so I think that's always a good question to ask at diagnosis of looking at school concerns, who would be the best person to help me advocate, but also to learn like what should be things that I should be monitoring. And one thing that we hadn't really talked about is what our school liaisons can also offer is educating classrooms. So when we think about the social dynamics of having a cancer diagnosis, oftentimes peers and classmates, like they don't know any other kids with cancer, right? They don't know what cancer is. There can be a lot of fear. And so that can be another role where our school liaisons actually visit the classrooms and they read a book and they provide developmentally appropriate education, which usually helps the patient because then they don't feel like they're answering all of the questions, right? And that their peers can get a better understanding, and also really helps when they return back to the classroom that their classmates have had some education on like what to expect and what things can be most helpful for a child with cancer. So for Ben, when we started getting the school liaison involved, she had met them early on at time of diagnosis, but he did have a pretty extended admission. And so the homebound instruction was started about a month after, just given all the complexities with the admission. And that was something the family really talked about, of just being patient, right? There's so many obligations that families are balancing. And sometimes you feel that pressure of like, we've got to figure out the school thing right away. And while school is very important, we also recognize there's a lot of other things that you're navigating. So it's okay to take time when it makes sense to address those within a reasonable time frame. As I mentioned, he already had a 504. So the next step was transitioning it to an IEP because he had a brain tumor and he had more of that direct impact, qualified under that other designation for the traumatic brain injury. And then so we updated the accommodations to best support him, which included home instruction. It was 1 hour a week where an instructor came into his home to work with him. But then when he was in the hospital, we also had a hospital teacher, which was really helpful. So he was able to develop a relationship with the teacher who could bring in classwork. It would also give parents a chance to have a break because, again, we recognize you're balancing a lot of things once your child is diagnosed. And some things that we talk a lot about with families is, we recognize when kids have cancer, it's hard to know when they're feeling well. It's hard to know when they're not going to feel well, right? So we talk a lot about activity pacing and when the child's feeling well, trying to take advantage of those moments. But sometimes these kids may need extra rewards to motivate them, right? Because they're already being asked to do so many other hard things. So being able to problem solve of what would be something kind of like the if-then command, right? So if you complete these 5 math problems, then maybe you can have access to 30 minutes of your favorite video game. But being able to help motivate that, knowing they're balancing a lot of hard things as it is. And then the other component, as we talked about from a social lens, is we know that for kids with school, it's a social experience, right? So it's not just the academic experience that they miss out on, but they miss being connected with their peers. So these are just a variety of ideas that we can think about of ways to connect patients with their classmates and friends. And so, some of these are very simplistic of like, frequent communication with the teacher. Sometimes you'll see, peers and classmates will make lots of cards and they'll send them to the hospital. But there's also other organizations that have been really helpful. So when you think about Hope Can, they offer a tablet so that you can connect with the school, especially if there's difficulties accessing certain electronics, and that could be something that they could use to remain connected with their classroom. Monkey in My Chair is another really popular one. You can see the picture here in the right bottom hand corner, but essentially you get a big stuffed monkey that gets to sit in the child's seat. The child also gets a smaller monkey to know who's sitting in his seat. And then there's different websites and communication patterns that they have so that the classmates can talk back to the patient. But that's been a really good way for them to feel included. And then peers will take pictures with the monkey and they'll send them. So I think there's just a lot of ways where kids can feel like they're still a part of the classroom, even if they're not physically present. So I'm sure many of you have heard this metaphor when we talk about cancer treatment, but oftentimes we describe it as a roller coaster, right? And so we think about there's many different phases of cancer treatment, from diagnosis to beginning treatment to getting halfway, which is exciting. You have unexpected hospitalizations, but then you get to the point where you're at life after treatment, right? You've completed your treatment. And there's a lot of idea that at this time, families, it's pure joy. They're very excited to be there. And while joy still exists, we recognize that when we start to talk about life after treatment, there still can be a lot of fear for patients and families because for however long their treatment was, they've created new routines. They may have not seen family and friends as much. They don't have their typical routines. And so it feels really scary to get back into that part of life. Also recognizing if there's some challenges from diagnosis and treatment that now they have to figure out new ways to reintegrate back to normal. So back to Ben's case. So he finished treatment at the end of the fall, and then about 2 months later, he underwent neuropsychology testing. This was the goal, to get a better understanding of where he was at so that we could best prepare for his return to the classroom. And so overall, what they found with neuropsychology testing was, thankfully, his intellectual functions were still within age expectations. So that was great news for the patient and family. His academic achievement was also at or above expectations. So strengths in reading, which was great to see. He was doing fairly well in math, but because of some of those fine motor skills, so again, like the copying and some of the paced activities were much more difficult. They noticed worsening impairments in terms of attention and motor skills. Like I said, he already had ADHD at baseline, but then some of these were worsened, again, given to tumor location and also the treatment that he received. And one thing that was really important to note during his testing experience was he became easily frustrated. And a lot of that was related to, he loved school and school meant so much to him. And so coming back to do this testing and realizing that things were more difficult was really hard for him. And during a lot of the task, he would make remarks about like he wasn't smart anymore, or how is he ever going to get back into school. And so again, this really helped us by seeing how he presents and like what that would look like for a school day to help encourage him, knowing that it would be a bit more challenging for him when he goes back. And as we mentioned, all of his profile from what we learned from testing was very consistent with what we would expect based on his diagnosis and his treatment. So on the psychosocial front, I think it's also important to recognize for Ben, throughout his treatment, he was feeling socially isolated. He talked all the time about feeling alone, and all he wanted was to feel normal and be able to go to the park and play with his friends. And then also all the physical things, right? Like getting a port or having a shunt. From that physical lens, he no longer felt like he looked like his peers. So some of the worries Ben talked about throughout his treatment was, will I ever be the same student I was before? I was really good at math. Like, will I be able to do that again? He talked about, will kids make fun of my shunt when I return to school, right? So he still didn't quite have hair as he was finishing treatment. So you could still see that. And that was something that he was understandably very self-conscious about. He wanted to know when he got back to school, would his classmates and friends only see him as the cancer kid? And he would talk about like the pity party. He didn't want that because he wanted to feel normal and he wanted to be seen for all of the other things he was good at. Would he still be able to become an engineer? So if math is hard, like, will he still be able to meet that goal? Will he still have friends when he goes back to school? He hasn't seen a lot of them in a long time. Like, will they still remember him? Will they still want to play with him? Have they moved on? And then will he be able to keep up with his friends? I would say that was one of the biggest ones because, again, he recognized from like that growth motor that it was really challenging. So he used to be outdoorsy and he would run around and jump on the playground, and all of those things are going to be more challenging. And so he was really worried how he would still do those activities. So I think, in these situations, as many of you probably relate to, it can be really easy to focus on all of the risk factors, right? Pretty complex medical history. He's missed a lot of school instruction. Family was experiencing a lot of stressors, and he has missed a lot of social opportunities throughout his treatment. And while we recognize that all of these risk factors can be very challenging to cope with, we also think it's really important to highlight those protective factors, right? So neuropsych testing showed us that he still has intact intellectual function. He's very strong from an academic lens. And then from a psychosocial, he's very empathic, he's determined, he's motivated. And so being able to include these types of protective factors in conversations to help encourage kids can be really helpful as they reintegrate back to the classroom. So these are just some recommendations that were helpful to Ben, and I'm not going to go over the school ones because Dr. Hoskinson talked a lot about some of those that could be helpful. But we also think about kids also exist in their home setting, right? So what can caregivers do to help support kids? And I also like to talk about, it doesn't have to be just caregivers, right? It can be grandparents, aunts, and uncles, and siblings, and everyone can help out to best support that child when they're at home. So things like creating consistent routines, right? When you're through treatment, you have hospital admissions and your routine is just very different. So when you get back into that normalcy, what routines are you going to create to help create that structure for your child? You may use timers and alarms. So when he's getting ready for school, right? Maybe it's so long that he's like eating and getting dressed, right? Those things to kind of help keep him on task so that he can arrive to school on time. You might use visual schedules because he may forget if you give him too many steps, right? But if he could follow a visual schedule, that might kind of help him stay on task as well. Reward systems, taking breaks. So again, activity pacing, whether they're doing chores or completing their homework after school. And then practicing those coping strategies so that they just become natural when he's in the school setting or home, whether that's positive self-talk, taking a deep breath, taking a walk, or engaging in some other preferred activity. And then when we think about supporting Ben after his treatment, so one of the things we always talk about is continuing to stay connected with your hospital support. So knowing that even when your child completes treatment, all these providers are still here and wanting to help you. So please update them on the best ways that they can support you. We talk a lot about with the pacing, but also that gradual reintegration. So when they think about going back to school, do you start maybe with their favorite class, or maybe it's the lunchroom, right? And then maybe they go back for 2 classes and gradually extend that over time. Same thing for like a social experience. Maybe you start a play date before they go back to school so they can have like a one-on-one experience. And then sitting down with your child to talk about like, who are your go-to people? Who are people that you trust at school? If someone does say something unkind or bullying, what could be your plan? Who will you tell and what will we do? And then obviously just being able to practice grace and praise them for their gains, of thinking it as a stairwell, right? It's one step at a time rather than feeling like you're going from 0 to 360, recognizing recovery takes time. And then thinking about, sometimes our kids, and Ben mentioned this too, sometimes they may be hesitant to use accommodations. So some reasons we get is, they already feel different because of their cancer diagnosis. And so having accommodations continues to make them feel different. They just want to feel normal. It makes them feel like maybe there's still something wrong with them because they feel like they're getting something extra, or the other kids may say something that they're getting because that child is not receiving it. Sometimes kids are shy and it's hard to ask for help. So being aware and understanding your child's willingness to use accommodations can also help support them in the classroom. And for kids who are hesitant to want to use accommodations, I always like to show them this visual, and it seems to be really helpful. And what we really talk about is when you think about equality, that's giving everyone the same thing. But when we think about equity, it's more of leveling the playing field. So kids may have access to different opportunities to access the educational instruction that they deserve. And usually when you show this picture, it helps them understand, and it doesn't take away all the stress about it, but helps them understand about leveling the playing field and how we can best support them to use accommodations. And then I would be remiss to not talk about siblings. We talk a lot about how we support patients in the school setting, but we also know that siblings are at risk. We know they may miss more school, or they may have difficulties focusing in the classroom. Their grades may become lower when their brother or sister is diagnosed. Or we have some of the siblings who really want to please mom and dad, right? So they're trying to do as much as they can so that they're not another burden for their family. They may also have social difficulties because it can be hard to relate to peers who have no idea what it's like to have a sibling with cancer and who's facing a life-threatening stressor. So it's very similar tips of what we would recommend for patients, but being able to talk to teachers. Sometimes they may forget that, yes, this sibling has a significant stressor. And although it may not go to an extent as a 504 and IEP, there are certainly accommodations that schools will be willing to work with to support siblings in the school setting, whether that's modifying demands, having more peer support, and really just increasing that communication between teachers and caregivers so siblings can be best supported. And lastly, I would love to talk about where Ben is now, because again, I think when we think about all of those challenges, it can be really easy to focus on that. So Ben is now 1 year post-treatment. He is attending school for full weeks, full days, most of the time. He has made a lot of new friends, which has been really exciting for him. He did lose a few friends, but the way that he perceives that is he really learned like who was going to be there for him during the hard time. And he's found that to be a silver lining of his experience. From a rehab perspective, he's still very much working on his gross motor skills and strength. So he hasn't been able to do as much of those outdoor activities as he did, but he's really getting into Legos. He's joined the robotics club. And so he's still on track to becoming an engineer. And then really from that psychosocial perspective, he's been like a great mentor for other kids, sharing experiences and how you go through hard things, and how he's been able to kind of use his difficult experience to continue following what's important to him. And so I would just like to land that as we think about kids, although they have lots of challenges, kids are very resilient, right? And they still find ways to grow and change from these hard experiences. And so as they go through all of this cancer experience and throughout their treatment and beyond, thinking about their needs may ebb and flow over time, but we would encourage you all to remain connected to your support so that you have all of the people in the community that you need to best support them no matter what phase they're in.
Wow, thank you, thank you for this amazing, robust presentation. I know that our Q&A is filling up, and Kat's going to jump on board here and help navigate some of these questions that are coming through. And I know we want to get to it and be mindful of everyone's time tonight also. If anyone feels compelled to do so, I know we don't have a lot of ways to communicate with our panelists, but if you want to throw something into the chat or give a reaction for the benefit of tonight's presentation, that's always welcome too. So I will hand it off to Kat.
Hi, everybody. Oh my goodness. Thank you so much. That was a wonderful presentation. As a parent who has a kiddo who has a lot of late effects and struggles with education, this was really informative. So thank you. We've got a good number of questions that have come through. Some of the stuff that's coming out is can you talk a little bit more about the hidden and unseen challenges that our kids have, and how can we better communicate with our educators who maybe don't have experience or an education background that helps inform them on how to deal with these unseen, really unknown issues that some of our kiddos are facing, that might be more behavioral, perhaps, but are really truly rooted in their treatments, tumor locations, etc. Do you have any advice? Anyone can take that one.
I was going to say Megan or Emily may have some thoughts about that one, since they work regularly with families directly.
Yes, I think that is a great question. I appreciate you talking about the hidden challenges. I think a lot from that lens, as you said, like behavioral, and then teachers might make assumptions, and then that carries with them grade to grade, which makes it really challenging because there's, as you said, so many things that are out of their control. And I think that's where it becomes really helpful, depending again, what access you have to supports at the hospital. So is it the oncologist who could talk about some of the effects, right? Is a psychologist who could advocate of like, these behavioral concerns may be contributed by X, Y, and Z, and these are the strategies that are most helpful. But I think it's really finding a member on your hospital team who can reach out to the school and advocate and educate, because I do think that systems, they are more responsive when they have that direct line of communication. And we always see it as like, sometimes people just don't know, right? And so giving them the chance to understand of like, these are some things that we might see, and we don't want that to always fall on caregivers, because that can be a really heavy burden when you're trying to keep explaining what things might be contributing to changes in your child's academics and behavior. So I would really try to find a member of your care team who can help bridge that connection and provide education, especially to those hidden or unseen, that people just may not be aware of.
That's great. And you know what? Somebody actually made a comment. It wasn't a question, but in our chat about kids and their child was the grade 7, right? And they're diagnosed, and there were kids who thought they could catch the cancer, right? And their oncologist did a call with the class to help explain it. And what a great oncologist. But there might be something there a little bit about thinking outside the box as a caregiver in how to actually explain some of these things that feel really heavy, really burdensome, and really inexplicable sometimes. And we're overwhelmed because we don't really know how to express it. And ultimately we're protecting our child. So I love that advice of finding somebody you're comfortable with on your care team, to kind of help you bridge into the school. Somebody's curious, and I'm actually very curious. How prevalent is ADHD diagnosis? Or is there an increase in this particular patient population?
I could take that one. It is more prevalent. And so neurodevelopmental, so just ADHD that, is more kind of either hereditary or, kind of condition learned. The prevalence rate is between like 8 and 10% in the population. It's a little bit more common in boys than girls. And especially in boys, it tends to be diagnosed as kind of the more hyperactive, impulsive side. Oh, okay.
That was awesome.
Yeah. Whereas there's a literature in cancer specifically about what's called secondary or acquired ADHD, and that's what's more commonly seen in kids after treatment. And the interesting thing about that, so that occurs in about 25% of survivors, and so it's much more common. It's more common in kids who get treated using neurotoxic treatment, either chemotherapy or radiation. And it tends to not be the super fidgety bouncing off the walls type of ADHD. It's more so kind of that inattentive, zoned out, not paying attention, kind of lapses, seems to be staring off into the distance. And so, one of the unfortunate things about that is that type of ADHD just isn't sometimes as apparent. So when we were talking about things that might be overlooked or missed, these are kids who are not, the bouncing off the walls troublemakers. And so sometimes that difficulty is overlooked, even though there are some types of behavioral strategies and medications that can be very helpful, even for kind of the secondary ADHD.
That's really interesting. Thank you. Thank you for that. Another question, and I don't know if there's a couple of questions about access to the slides, and we can loop back with you all on that. But another question is also finding access to support for kids. So we've talked a little bit about caregiver support, and there becomes resources right when the kids get a little bit older. But what about those younger kids, that 10, 11, 12, not quite AYA? Where can they find support? Do you have any recommendations?
I would say one of the things that, a lot of our families find helpful is just kind of having a chance to do camp. It's a, kind of easier short-term sort of connection with others who are survivors or going through treatment. And, it's normalized in a way that doesn't feel like you're in a support group or getting, therapy at the moment, which can be hard for those tweens. But I do think that ways to connect. I think Emily had some of those resources in her slides that families can access. The other thing, support groups have been hard at our institution, at least, and several of my colleagues that I've talked to, because of just the timing and challenges, I think, with connecting at the same time with kids with their busy schedules. So I think that's why some of the camps have been more popular among our families. There's also some programming, and it's become more of a national program called A Kid Again. And it actually started in Ohio, and now they're branching out across the country and providing a time, what they call a timeout from illness. They provide fun activities for families to engage in. So it might be going to an amusement park together. It might be going to see like a professional baseball game or something like that, where families can connect around an activity, and it doesn't have to be just about kind of sitting and talking about their feelings, which is a little easier, I think, for kids to engage in. So I would say those kinds of activities may be a little bit easier than a traditional support group kind of model, but some others might have some ideas too.
I'm going to make a plug, actually. So one of the ways that I have approached this personally was utilizing local support that I found resourceful, and then, kind of using my own personal connections to then find other kids that my son could connect with. He's going to a support group, or even engaging online, and it wasn't for him. So literally found one child that he could connect with, and it made sense. And that made all the difference. So I do think that sometimes it's very little baby steps, and just finding somebody that makes them feel like they have somebody on their team that maybe isn't their mom and dad. So it can be little, right? And we, as Momcology too, please, we have groups that deal with the late effects, after effects of cancer, teenagers, all of that stuff. And we can kind of work together and find resources for our kiddos, even though that's not exactly what we do.
And one other thing
It
that,
looks
that
like
I
she wants
did
to say
just on
something.
on a very, personal note, which really changed things for my son when he was in treatment. He was around that age, 9, 10, 11, was to, from the school level, to have a friend go with him to treatment each time. And it was almost like a mini field trip for that friend. And he would learn about, what that world was for my son, between the blood draw, sending the blood up the tube and the whole thing. So it became a really fun thing, I think, for the class, like who's going to go with Matthew this time? So it became an interesting thing at the very, a little bit more work for me, but but we do what we have to do, right? And it was game changing for him just to be able to be empowered and feel like the host in that environment. So just a little thing that us momcologists can exchange with each other, helpful bits.
That's really cool. I didn't know that story. That's really cool. I'm going to do one more question. How about those situations where maybe your child is facing some challenges, but they're not necessarily obvious neurological or physical, but they're being denied? Are there resources to help support the cause for, okay, this child still needs some supports? Lots of head nod.
Yeah, I think that's a really hard situation that a lot of families unfortunately find themselves in, especially because, as Dr. Hoskinson shared, these, challenges sometimes kind of sneak up over time, and they might seemingly appear out of nowhere, years after kind of the diagnosis and treatment ends. And so I think, just kind of leaning into, continuing to bring up those concerns and kind of pushing for, repeated testing, even if they were tested several years ago, saying, okay, well, things have changed, demands have maybe increased, especially some of those periods where we tend to see like some more difficulties kind of pop up, or like that third grade transition, middle school transition, high school transition period. So kind of, even if they're not qualifying at this exact moment, kind of, keeping that on the radar. And then I think also just pointing I think to, Dr. Schaefer's point of like finding your allies also within the school system. So we talked about finding your allies within the healthcare system, but maybe there's a teacher who, even if they don't have formal accommodations, maybe there's a teacher who, has found a way to kind of manage behavior in the classroom or provide notes in a certain way that just connects with the child. And so encouraging maybe that teacher to kind of communicate with the next year's teacher or to kind of like pass along those hints. I think, starting it off with that like collaborative nature, it can be really, it's very frustrating when the school doesn't like want to provide those formal accommodations, but always trying to approach it with that, we're all here to work together and try to make the child be as successful as they can be over time.
No,
Yeah,
that's
and I
great.
think one of the frustrating things about, this area is that we know more about the likelihood of things progressing to an area where kids may need help as opposed to a child who's never had any health challenges. And so in some ways, we're able to kind of see the future a little bit more clearly than the academic system was really designed to address. And so it can be really challenging when the school system is built on this. You have to show a deficit before we're going to help you. And in some cases, they're really tied to what's called a response to intervention model, where first they'll set up like a little bit of help and see if you respond to that. And they won't set up a formal IEP, for example, until you've shown that you don't respond to that intervention, which just means you're going to end up being a little bit further behind. So I agree with Dr. Moscato that there's a lot of benefit to finding an ally in the school system.
There's mommy up there.
It's great.
That's mommy. And then that
To finding an ally in the school system, and then to also make sure don't feel like you have to shoulder that entire message on yourself. Use your social, your support team in the hospital, talk to your physicians. If you have a school liaison or a psychologist who's willing to be in direct communication with the school, that can also be really helpful. Another thing that I would recommend is, so all kids lose some academic footing during the summer months. It's very well documented that all kids go back in the fall, having fallen a little bit further behind than they were in the spring on things like reading and math performance. That difference, that drop is more pronounced in our survivors. And so anything that can be done, you want to make sure to give kids a break during the summer months, but just to keep up with a little bit of that academic familiarity. So reaching out to public libraries if they have story hours or programming for kids, anything that you can, getting them involved in, something like 4-H or Scouts that might have some, problem solving can be really helpful.
Actually going right along with that, and we only have a few more minutes, but I did want to say, because this ties right in, somebody asking about holding a child back or repeating a grade. Like, is that something that would be recommended? And then I would love to actually real quick, if we can close with sharing some of those academic liaison with like keywords, like here are your people to go to. And they might not be called the same thing at every hospital. So maybe if you can just share some of those people that can be on our team to help our kid. And even though they might not be called the same thing at every hospital, that would be super helpful. So the grade, holding a child, not moving a child forward in a grade. I don't want to call it holding them back, but not progressing them forward due to a lot of absences or falling behind. Is that a recommendation? And or also if you can provide some of those keywords.
Conjunction with like where your child is, are they earlier in the academic path? Are they later? And how they're doing both socially, emotionally, and academically. And those are hard decisions to make, but use the people around you who know your child, the medical team and psychologists or neuropsychologists at the hospital, as well as the teachers and folks in the school system that know your child to help you with those decisions.
I think that one's a very personal decision, right? It's super personal.
Right.
It's very difficult to answer that
Yeah.
in a bubble. So, but thank you for trying. Good attempt. Also, I think what would be great is we'll talk about the slides everyone that's on the call, please know that this is also being recorded and the recording will be made available. You can email us at events@momcology.org for information on how to access the recording. So you will have access to the information presented tonight. It was a lot. It was very, very, very educational and fruitful for all of us. Thank you so much. We will also put together a list of some of those keywords, and education liaison is primarily what's utilized, but your child life, social work, your hospital psychosocial team as a whole are all resources for you. And there are also, local resources as well. So we'll try and put together a little bit of a list for people that we can also distribute in addition to the recording. So I would just like to say thank you. Kim, do you have anything you wanted to add before we close out?
I just want to thank our amazing panel tonight, and again for everyone joining us and making time and making this time together as parents of children diagnosed with cancer meaningful. We always say it's not just about the diagnosis itself, but what we can do because of it. And I think that us being together and collaborating and communicating with each other leaves a brighter future for our kids. So thank you everyone for being here. Please mark your calendars to join us on April 20th for our next Caregiver Lounge with the topic. And I think this title is still in process, but the theme will be potential impact of cancer on a teen or young adult's identity and how to best support them. So another super important subject. We want to thank our sponsor, Day One Biopharmaceuticals, for their support in this educational series. And we conclude with that and wish you and your families a peaceful evening. We're always here to help. Thank you. Good night.